A very good morning and welcome to the Quality Measurement in Health Professional Education, Revisiting the Metrics, our international conference, which I'm very pleased that kicks off today with the pre-conference workshops. Assessing the quality of health professional education interventions is a task that appears more difficult than the comparable task with clinical intervention. What to measure, how best we can measure it, and so what are important questions we are struggling and trying to find answer to it. The aim of this conference is to create an opportunity for health professionals, educators, regulatory bodies, healthcare authorities, public and private healthcare services providers to interact with experts in the fields of quality and assessment, share experiences, and how to introduce new assessment methods in their own contexts. The speakers are scholars and leaders of innovations in health professional education. The conference will be an excellent opportunity to meet, discuss, and exchange opinions and best practices in the field of assessment and program evaluation. I'm very pleased and honored to present a great man, a scientist, a top neurologist, and one of the leaders in the movement of evidence-based healthcare, my very dear friend, Professor Kameshwar Prasad, the President, the Director, and Chief Executive Officer, Rajendra Institute of Medical Sciences in India. And with him will be Dr. Manya Prasad. Dr. Manya is Assistant Professor of Epidemiology at the North DMU Medical College and Hindu Rao Hospital in New Delhi in India. As you can see from the name, that Manya Prasad has inherited all the good genes from her father, Professor Prasad. I'm sure you will enjoy this workshop, and this, I would call it duetto between the two in running this very interesting workshop on the quality of evidence in measuring outcomes in health professional education. Thank you very much, Kameshwar, and thank you very much, Maya, for accepting our invitation.
Manya, Professor Kameshwar, the stage is all yours.
Okay, so let me start by thanking the Gulf Medical University for inviting me. This invitation coming from my great friend and a person who is also my mentor in medical education, Professor Hussam Hamdi. It was impossible to say no, and therefore, even with my limited expertise, I have agreed to deliver this workshop. And I'm a bit concerned that people in the field of medical education may not be very much familiar with the grading of quality of evidence, or certainty of evidence, or confidence in evidence. But I think in next 1.5 hours, we will try to at least sensitize the medical education community with what is probably the worldwide most accepted method of assessing the quality of evidence. I will hand over first to Dr. Manya, who will present how they do it in clinical and public health field. That will be just an introduction of what grade or grading of recommendations, assessment, and evaluation looks like. And then I will take it to the medical education field. So you can see already from existing literature, there are experts, authors who are using the similar framework or same framework to apply this to medical education field. And taking the generic aspect of grade, I think it is quite possible to slightly modify the approach and use it in medical education. And we are going to demonstrate to you that with some examples that it is already happening, and we will like that it happens much more frequently. And therefore, this will be more like, you can say, sensitization workshop. Grade workshops run for 3 days, 5 days, but in the limited time we have of 1.5 hours, we hope to sensitize you and may arouse interest for you to explore further and learn it, apply it in medical education field, and take it to further steps. So once again, thank Gulf Medical University and for giving me this opportunity. And I hand over to Dr. Manya to introduce grade approach as it exists in clinical and public health field. Dr. Manya, please.
Thank you so much. And I extend my heartfelt gratitude to Gulf Medical University for inviting me and giving me this opportunity to talk about a very important topic. I'll begin sharing my screen. So, Dr. Pooja, can you confirm whether my slides are visible?
Yes, they are, Dr. Manya, visible.
Okay, great. Thank you so much. So, I will be talking about one of the applications of epidemiology that's been the most groundbreaking or impactful in the world of clinical medicine and public health. So that's the first part of this workshop. And in the second part, we will attempt to extrapolate these ideas to medical education as well. This transparent framework for assessing the quality of evidence in medicine is already being applied in the world of medical education in a nascent way. And we propose through the framework presented here some ideas in ways that we can tweak that system in medical education, make it a little better, make it a little more advanced, and maybe reap the benefits that we did in the world of medicine through this approach. So what I will go through is first of all the introduction to the grade approach, and go through the steps in two parts. There are two main steps. The first is the rating of quality of evidence, and that is the main focus of today's talk. And then grade has a second part, which is from evidence to recommendations, and then I will talk about one example. So GRADE is an acronym. It stands for Grading of Recommendations, Assessment, Development, and Evaluation. And what it provides is a transparent framework for developing and presenting summaries of evidence, and it provides a systematic approach for making clinical practice recommendations. A little bit of history. It was in the year 2000 that the GRADE working group began to meet. So this was comprised of international methodologists. So methodologists, people like me who are trained to appraise the evidence, make syntheses of the evidence, and so on, and a new breed of experts called guideline developers. The first publication describing the approach appeared in the BMJ in 2004. Guidance for clinicians to understand and apply GRADE appeared in a 6-part series in the BMJ in 2008. So this is where clinicians can go to know what this is more, what this is about. And guidance for methodologists began as a series in the Journal of Clinical Epidemiology starting in 2011, and it continues to date. So I think they're up to the 33rd or 34th guidance document. It is a system that has seen an overwhelming uptake and endorsement. So organizations like the World Health Organization, the Cochrane Collaboration, the NHS, leading internal medicine organizations, and electronic textbooks like UpToDate and Dynamed have all endorsed the GRADE approach. And so this is something that we are going to be seeing around a lot, and possibly a similar framework may be as ubiquitous in medical education in the future. Certainly this is important to know about because it's seen an overwhelming uptake. So what is all the fuss about? Why do we care about the confidence or the quality in evidence? This cartoon appeared in the BMJ in 2008, and it presents the basic idea that is presented through this framework. There are two weathermen talking in the Weather Bureau, and one says to the other, I figure there's a 40% chance of showers and a 10% chance we know what we're talking about, which means that there's a difference between assessing the likelihood of an outcome and assessing how confident we are in that assessment. And ultimately, the value of the assessment of the magnitude of an effect, it ultimately depends on our confidence in that estimate. So this is what the whole idea is. How confident are we in the assessment of the likelihood of an outcome? That is done through this framework. In terms of medical curricula, it's become a core tool. So while earlier skills like critical appraisal were touted to be a core skill, and certainly for epidemiologists like myself, it's still a religion. But slowly people realize that clinicians and students of internal medicine and other branches, they don't have the time or the incentive to know about complicated tools of critical appraisal. And so understanding evidence synthesis or systematic summaries of the evidence, or knowing about the quality of evidence synthesis is sufficient for practicing evidence-based medicine, and this is what was suggested in this paper. So what are we grading? Let me give you the perspective from the medical point of view. Primarily, it's interventions, so management strategy 1 versus 2. But it's also been applied to other questions apart from management. Just a clarification, what is grade not about? So it's not about rating the quality of individual studies. So we are not concerned with the quality of individual RCTs or individual observational studies, but rather we are talking about bodies of evidence. The systematic summaries of the entire body of evidence on a particular clinical question. Now, ideally, this body of evidence should be summarized in the form of a systematic review and meta-analysis. Bodies like the World Health Organization, when they don't have a recent, updated, robust, strong systematic review and meta-analysis on a particular topic, they commission such a review to happen. So they will get around some methodologists and experts to actually synthesize the evidence on a given topic. So as I said in the beginning, it's more recently been extended to other questions as well apart from management. And so they have extended the grade approach to questions of prognosis and diagnosis as well, but we'll be focusing on management. Well, in grade approach, we are grading 2 components. The first is the quality of the body of evidence. So how confident are we? How certain are we? So all of these terms are used synonymously: quality, confidence, certainty, and evidence. They're all referring to the same thing. And this is depicted in the form of 4 discrete categories: so high, moderate, low, and very low. And the second thing we're rating is, in medicine, the strength of recommendation. And that's just a simple binary system of strong and weak. When we talk about the confidence, certainty, or quality of evidence, we can think about it as being on a continuum. So going from no confidence to totally confident. So totally confident would mean just do it. No confidence, you have to think about it, weigh in the pros and cons, values, benefits, etc. And then within this continuum, there's a discrete categorization. So very low, low, moderate, and high. This discrete categorization does bring about some arbitrariness, but it has the advantage of being simple to understand. So how does the whole system work? Well, what we begin with is RCTs and observational studies and systematic summaries of individual studies. Now, the evidence that comes from randomized controlled trials by default starts at high confidence. So a body of evidence from RCTs by default is at high confidence, and that from observational studies is at low confidence. However, evidence from RCTs may not land up or end up as being high confidence. So there are a number of issues that can rate down the confidence from high to moderate, low, and very low. And evidence from observational studies, though they start at low confidence, they may not end up as low confidence. So very often we can get high quality evidence from observational studies as well. So how does this happen? Well, there are 5 main issues that rate down the quality of evidence from RCTs. And I will talk just 1 or 2 minutes about each of these in subsequent slides, but I'll tell you what they are. An RCT would be rated down, the body of evidence from RCT would be rated down because of risk of bias, number 2, because of inconsistency, 3, indirectness, 4, imprecision, and 5, publication bias. So all of these issues can rate down from high quality to moderate, low, very low, and so on. And observational studies, though they begin at low confidence, may be rated up. Now, this happens most often when we have a very, very, very big effect from observational studies. And so, for example, there will never be an RCT, and there never has been an RCT on total hip replacement. It's not required because it's a very big effect that happens very quickly. Similarly, epinephrine and anaphylactic shock, very big effect, happens very quickly. We don't need RCTs. So that's high quality from just observational studies alone. There are many other examples: dialysis for terminal renal failure, furosemide for pulmonary edema, and so on and so forth. So whenever there's a very big effect, we would land up with high quality evidence from observational studies. And so this is how the system works. We keep rating up or down, according to that system. And then finally, we land up rating that in those 4 discrete categorizations that I told you about: high, moderate, low, and very low. So RCTs start high, observational studies start low. What can lower confidence? These 5 things, and I'll talk just very briefly about each of these. But first, let me tell you what the product of applying the grade approach to a body of evidence looks like. And so the product is in the form of a grade evidence profile. And I did come across a few of these in the field of medical education as well, a few papers that possibly we can discuss in the next session when we extrapolate to medical education. And so over here in the table, the first column is the outcome. So this was a systematic review of randomized controlled trials in hospital patients of pylorus conserving versus standard Whipple pancreatic chorioidenectomy for pancreatic cancer. So these are the outcomes that the trials have studied: 5-year mortality, in-hospital mortality, and so on. And then over here in the left side of the table, you'll see the quality assessment. So you'll see that these are the 5 issues that I told you could possibly rate down the quality of evidence from RCTs. And you'll see here that this body of evidence for this outcome, 5-year mortality, was rated down because of risk of bias, so study limitations, which is why it went from high to moderate. And then in the footnote, you can see why it was rated down. So it says unclear allocation, concealment, patients blinded in only 1 study, and so on and so forth. Similarly, in-hospital mortality is rated down twice. So once for risk of bias and another time for imprecision. So the quality of evidence is low, so it's rated down twice. So this is how the system works. And then on the right side of the table, you have something called the summary of findings table. So when we talk about the risk of bias from RCTs, what we are referring to is basically the methodology. So how well conducted were the RCTs. And we all know the mechanisms in place that are there to ensure the methodological quality of RCTs, things like allocation concealment, intention to treat principle, blinding, completeness of follow-up. And then more recently, there are issues like selective outcomes reporting and stopping early for benefit. Of course, we can discuss all of these issues in a session that's devoted to RCTs. But suffice it to say for now that what risk of bias is referring to is basically the quality of that RCT methodologically. So how well conducted was it in order to ensure that it is free from biases. So this is an easy one to understand. It's very intuitive. It's basically the methodological quality. Now, to understand the next one, let's digress a little bit, and I'll take you to a story of the dean of a college trying to deal with student complaints. So the student union writes to the dean, there has been a problem with the examination results. Some students who failed were actually good, and some students who passed were not good at all. So the dean appoints a committee and to examine whether this is really needed to be investigated into, and if so, then investigate the problem. So this is an overview of the examination that took place. So it had three parts. There was a written exam, the practical, and the oral. And each of these had a total of 100. So 100 for each of those three parts. And the pass mark was 50% of the total overall. So what the committee observed was that there are 4 patterns into which the students fall with regard to the result of the examination. So these are the parts of the examination that you can see here, 100 total for each part. And then these are the 4 patterns that students are landing up into, right? So the first pattern in which 165 students landed up into was this, that they had around 55 out of 100, around this much for written, around 60 out of 100 for practical, and around 65 out of 100 for oral. So this was the first pattern. The second pattern was 15, just 15 for written, 70 for practical, and 80 for oral. This was the third one, 40, 45, 35. And this was the fourth pattern, which just had 5 students there, 90, 20, and 25. So my question to you is, and if you can type into the chat box or you can unmute to speak, you can tell me, are you concerned about any of these 4 patterns? And if so, which ones would you possibly be suspicious about? Or which patterns would make you kind of raise an eyebrow and say, there's something going on there that's kind of doubtful. And that could possibly impact the credibility of that, examination result. Or you can just type it into the chat box. Yeah, so a lot of people are saying pattern 2 and 4. And Dr. Pooja, can they really unmute and speak here also?
Yes, absolutely, Dr. Manya. They can raise their hand and then we will request them to unmute. Yeah.
All right, so that's great. So if you want to raise your hand, Dr. Pooja will just go ahead and unmute you, and you can just shout out your answer, or you can just say why you think it's pattern 2 and 4. Because I can't do that from here, so Dr. Pooja will have to unmute you. There's an overwhelming number of people who are giving patterns 2 and 4, of course. And does anybody care to raise their hand and speak out why they think that is? Okay, so I think probably what you're thinking is this, that with patterns 2 and 4, there's a high discrepancy with regard to the 3 parts. So while patterns 1 and 3 have fairly high consistency with regard to there being a consistent pattern across the 3 parts of the examination, over here you can possibly see that these students they got just around 15 marks out of 100 in written, and 70 and 80 for the other part. And over here, these people got written 90, whereas in practical and oral, they just got 20 or 25 each. And there was a previous group that said, these people are possibly, faculty students or faculty members or something like that. And these people got the paper leak. So, this is very intuitive because there's high degree of inconsistency across 3 assessments, right? Okay, yeah, great. So there's somebody who's raised their hand. Yeah, you can just go ahead and speak if you're allowed to.
Yes, it's okay. Can you hear me?
Yes, I can hear you.
Yeah, okay, Dr. Nermeen. Yes, I think the problem here is in the oral exam regarding the examiners, because the grades they are giving is not matching with the written exam, and the written exam actually is one for all the students, and it's more objective. It's not subjective. The one exam here is the subjective one is the oral exam, because it depends on the examiner and on many factors actually.
Right. So which patterns do you think are suspicious then out of these 4? Do you think which pattern out of 1, 2, 3, and 4 do you think is suspicious? Although we've already said the answer. But yeah, let's just reiterate it here and re-emphasize.
No, it's not a suspicion regarding anything, but I think, the oral exam is not an objective one. It always depends on the examiner, on his mood, on the type of questions he's asking. It's not very objective like a written one. And especially if you are, if there are many oral examiners, okay? It's not only one. It's not applicable to be one to examine maybe 100 or 200 students in an hour or 2. So we are always choosing 3 or more oral examiners to examine the students, to assess them, and they are not all having the same, let's say, not qualification. Sure, they are qualified, but maybe the same mentality, the same personality. That's it.
Exactly, right. So yeah,
Thank
so
you.
you're saying that there are 3 different types of assessment, and of course each has its own advantages and disadvantages. That's completely correct. And you agree probably that within these 3 assessments, what we would be comfortable seeing is if there is some degree of consistency across those 3 assessments, which is represented in pattern 1 and 3, and not so much in pattern 2 and 4, right? So patterns 2 and 4, as so many of you very correctly typed into the chat box, are patterns that you would want to investigate further. And they are unacceptable because the marks are dissimilar across various evaluations. And it's acceptable when the marks are similar. So any scientific word or synonym for similarity, and I'll just say the answer here, yes, there is a word for that called homogeneity. And the opposite of homogeneity is heterogeneity, right? So acceptability of the assessment depends on similarity across evaluations. Similarity, another word for that is homogeneity, dissimilarity, heterogeneity. And the way that we extrapolate this to evidence synthesis is that very often what we're doing for medicine and what is also purported now for medical education studies is to make evidence synthesis. If you happen to come across that paper I had shared in the pre-reading material, it's basically synthesizing, making a systematic summaries of all the evidence out there. The statistical technique to do that for studies of clinical medicine is meta-analysis, and each study that's included evaluates and measures the effect, and the summary effect is the average. The result is acceptable if there is homogeneity across studies, and if there is heterogeneity, we need to investigate further. And so acceptability depends on similarity across evaluations. We don't want to combine apples and oranges, all right? And the way that we can identify this in a meta-analysis, or that's the statistical part of combining the results of individual studies is by looking at the point estimates and the confidence intervals, right? So the point estimate is the best guess from the available data from that study. And this confidence interval is basically, you could think about it as the margin of error. So it's the whole range of values consistent with the data, right? Now, over here on the pattern on the left, you'll see that there's considerable overlap in the confidence intervals, whereas over here, you'll see that they're all spread out everywhere. And also with regard to the point estimates, over here in the pattern on the left, quite close to each other. And over here, it's really like scattered all over. If you try to put a skewer through this, it will go right through all of those bars. Whereas over here, there's no overlap at all, almost nil. And so this is how you identify it from looking at the forest plot from a meta-analysis. So this is a pattern we're happy with. This is a pattern that, is raising some suspicion. And so that's the second thing that can rate down the quality of evidence from RCTs, that is inconsistency. So the grade system uses the term inconsistency, but it's basically referring to similarity of the assessments, the estimates from various assessments. It's referring to homogeneity, how much heterogeneity is there in those assessments. It's basically referring to that. So if you have similarity of point estimates and if you have overlap of confidence intervals, we're happy. Right? So that's the first way to identify inconsistency. That's by visual inspection of the forest plot. And the second way is through a statistic called the I-squared statistic. And this is basically, again, a continuum, ranges from 0 to 100. And around 50% is where we start to get a little bit concerned. So less than 50, we're okay. We don't, or we're not very concerned about the level of inconsistency. And if you go more than that, then we start to get a little bit concerned. So those are the two methods to investigate, or not investigate, but identify heterogeneity by looking at the plot and by looking at the I-squared statistic. So over here, you'll see that when there's consistency, I-squared is very low. Over here, it's 0. And when there's inconsistency, it's quite high. So it's around closer to 100, right? 80, 90. The third thing that can lower the quality. So the first two things, the first was risk of bias, second was inconsistency. The third is indirectness. So what this is referring to is basically differences in population intervention comparison, comparator and outcome between that in a trial versus the population that you want to apply those findings to. And so, if a population that's included in the body of evidence from trials, older, sicker, has more comorbidities, then you would be concerned about applying those results to practice. Interventions, the dose may be differing, the kind of drugs may be differing, etc. Comparator, it could be standard of care varying across different contexts. And with regard to outcome, short term, long term, and you will see examples for medical education in the next presentation. That's part 2. But suffice it to say for now that what this is referring to is basically, differences in population intervention comparator outcomes from the body of evidence versus where we're applying it. And the fourth one is a very important one, which is a little difficult to understand. So I'll tell you a story. That's publication bias. So very high likelihood of publication bias raises doubt. So it lowers the confidence of estimates. Now, what this is about is that, studies that show a positive effect or show effects that are statistically significant are more likely to be published. And not only are they more likely to be published, but they're also more likely to be published faster. They're more likely to be published in better quality journals, or they're more likely to be published in English. And then related to all of those points, they're more likely to be cited. Right. So let me tell you the story of thrombolytic therapy. Streptokinase, there were a number of trials that have been conducted, and they all started way back in 1960s when the first trials came. Now, this graph is similar to a forest plot that you saw previously. So this line in the middle is the line of no effect. So this would mean that there's no effect of this intervention, no effect of thrombolytic therapy. And over here, the point estimates are again the best guess from trials. And these horizontal lines are the confidence intervals. So that's the margin of error. The way this is differing from a standard forest plot is that each of these estimates, the point estimates and the confidence interval, they are pooling the results from all of the trials conducted until that time point. So these are not individual studies, but are actually, all of them are pooling the results of all the trials conducted up till that time. So this is a cumulative meta-analysis, right? So Antman et al. In 1992, they took a look back. They took a look back to see how did the story evolve. So you can see this is the first trial, of course, very low confidence because, it's going right from here to here. And so really this is not indicating any benefit or any harm at all because the confidence interval is too high. Now, as more and more trials happened, you can see that it started becoming more and more certain, the role of thrombolytic therapy. Over here, by 10 trials and 2,500 people around 1970s, mid-1970s, it started to become clear that thrombolytic therapy does have some role. So this is mortality, and everything on the left is indicating reduction in mortality, and the right side is indicating increase in mortality. So by around 10 trials and 2,500 people, it started to become clear that there may be a reduction in mortality, but then the confidence interval is too wide to really warrant any kind of certainty in this estimate. By 27 trials and 6,000 patients, it became pretty clear, so there's a sufficiently small confidence interval, which is all towards the side of benefit. P-value is also pretty low. So you could say that the answer was in somewhere here, that streptokinase reduces mortality in myocardial infarction. Now, despite the answer being in, there were so many more trials that took place. So 30 to 70 trials, that's around 40 trials more took place that enrolled around 42,000 more individuals into trials, half of which did not get the benefit of life-saving thrombolytic therapy. Now, why was this necessary? Well, it was necessary because you see here that though the answer was in by 27 trials and 6,000 patients, there were no systematic summaries that could catch or that could detect the signal. So these were all small trials and they were all showing a benefit, but there were no meta-analyses at that time. There were no systematic summaries to pool the effect of all of those small trials. And it wasn't until, in the late 1980s when a big trial happened, the ISIS-2 trial, which enrolled 42,000 people, we required that big trial to translate this benefit into practice. So this is when people started adopting streptokinase, even though the answer was in way back. So this example is actually, touted as one of the victories of meta-analysis when we say that what is the evidence for evidence-based medicine? This is the example that's shown in the face of people who question that principle, because we need systematic summaries of the evidence in order to translate it into practice. The story of magnesium is the opposite. So in 1991, there was a meta-analysis of small trials of magnesium that said that it's an effective, safe, simple, and inexpensive treatment for myocardial infarction. And this meta-analysis was all done in small trials, so 1,400 patients only. But the big trial, the mega trial ISIS-4, 58,000 people, showed no benefit. And so this was said to be a blow to enthusiasm for both magnesium and meta-analysis. Now, what went wrong? Why did the meta-analysis not reveal the correct answer? As was observed in the previous example of streptokinase. This analysis shows us why. You could see that this was a paper that was published in the BMJ's misleading meta-analysis. And you can see here that, a number of trials, if you compare the magnesium example with the streptokinase example, you'll see here that, most of these were small trials that showed a positive effect. Whereas over here, you see that, the streptokinase did have bigger trials as well. And if you plot the sample size of the trials to so this is the sample size of the trial to the effect from the trial, you see that, the estimate from the small trials for the magnesium example is at odds with the result from the big trial. So while the small trials are showing showing a benefit, the ISIS-2, the ISIS-4, the mega trial is showing no effect. So this is at odds. And you'll see why from here, because this is where the small trials with negative effects would have appeared, and they're all missing, right? So this is publication bias, that small trials that showed showed no benefit did not appear, did not get published into the literature, which is why the meta-analysis of these small trials of positive effects led to a misleading estimate. Whereas in the streptokinase example, you'll see that small trials are scattered symmetrically, so there are negative studies as well, which is why the meta-analysis from those small trials is in agreement with the mega trials, right? So this is a common way to but try to assess the presence of publication bias. This is called a funnel plot. And what we observe in the funnel plot is basically the symmetry. We would be concerned if there's a chunk missing, like there is in the example of magnesium. It means that small trials with negative effects or with no benefit are missing from the body of evidence, which is why it's skewing the result in a wrong way, right? So that's the fourth concern with quality of evidence. This is the first. I'll reiterate the first one: risk of bias that we saw. Second was the example that I gave for the dean, and that was inconsistency, right? And the third one that we talked about was directness, indirectness, and finally it was publication bias. In the interest of time, I think I'll just very briefly talk about imprecision. And what imprecision is referring to is basically whether we have enough numbers in the individual trials or not. It could be the total sample size or a small number of events. And what imprecision, the way that we identify it is by looking at the confidence interval. So if the confidence interval is too wide, it means that there's uncertainty, so there is imprecision. And how do you decide if it's too wide? Well, you look at the two ends of the confidence interval, and if your decision changes at the two ends of the confidence interval, then that means it's an imprecise result, right? Okay, and then finally, there's something called the evidence to decision framework, which takes into account a lot of other issues that impact the quality of the evidence. So in medicine, as you can probably imagine, it's not just finding a signal, it's also values, preferences, balances of effects, cost effectiveness, equity, and so on. And so all of these are taken into consideration when we're building the evidence decision framework. And this is an example of how we use the GRADE approach to make a systematic summary of the evidence and apply it to practice through a recommendation. This was a systematic summary where we synthesized the evidence very early on in the pandemic on corticosteroids for COVID-19. So I think we began the evidence synthesis in March 2020, and this was released in May 2020. And this was a time when there were no trials on COVID-19. So we took indirect evidence. So this is an example of indirectness. We took trials that were done on other coronaviruses, so SARS, MERS, and so on. And then we applied the GRADE approach. We assessed the quality of the evidence for corticosteroids by taking into consideration all of those issues of risk of bias, indirectness, inconsistency, publication bias, and imprecision. And then there was a guideline group that sat in, and there were a whole number of experts and other people who sat into the guideline panel, including patients. So if this system is ever extrapolated into medical education, probably we would want an end user or a student to be there on the panel. And finally, the panel made a recommendation. Okay. So in conclusion, the GRADE system provides a transparent framework for rating quality of evidence and then translating that into the strength of recommendation. It provides explicit guidance that's transparent and informative. It's not inherently a simple process, but GRADE makes it as simple as possible, and it's systematic, and it is very widely adopted in the world of clinical medicine and public health. It's quickly becoming the worldwide standard, and this could possibly provide some guidance for assessment of evidence in healthcare education, which is a very fast developing field as well. So thank you very much for your attention, and I'll stop sharing, and I'm happy to take any questions in the Q&A session. Over to you, Dr. Pooja.
Thank you, Dr. Manya. Before we move on with Professor Kameshwar's presentation, Dr. Manya, I see that we had two questions in the chat box. There's a question from Dr. Shafan Khan, and he asks the effect of publication bias and how to get rid of it.
Right. So thank you, Dr. Shafan, for that question. The effect of publication bias, as I tried to depict through those examples of magnesium, is that it will bias the overall estimate from the evidence synthesis towards skewing it away from the truth. So what publication bias is basically studies that do not have a positive effect, do not come into publication. They're less likely to be published, they're less likely to be published in English, they're less likely to be cited. And so if what our evidence synthesis contains is just those studies that have a positive effect, then what the evidence synthesis will churn out is also, is also biased effect. So the evidence synthesis only churn out whatever is the quality of the included study. So if that is bad, then that truth will be affected. How to get rid of it? Well, bad news is that publication bias is still one of those things that doesn't really have a very robust method for either assessment or dealing with. So it's one of those fields that leaves a lot to be desired in terms of new methods for assessment, new methods for dealing with publication bias. We can never really be sure that there is no publication bias in a meta-analysis, right? So which is why we always say it's either detected or not detected. We can never say publication bias is absent because we don't have a very robust method. There are a number of ways to assess publication bias. I showed you one of them, that was the funnel plot, but there are a number of other statistical techniques. And how to get rid of it? Well, there are some mechanisms that are in place to try and avoid publication bias. At least in the world of randomized controlled trials, we require that all the RCTs be registered now before you embark upon conducting those RCTs. So even the international consortium of editors will not publish a trial unless it is registered. So if you have pre-registered trials and all of them are registered before they are conducted, we will know if any of them go unpublished. So that is one way. There are other ways as well. There are statistical ways to try and nullify the effect of any possible publication bias beyond the scope of this lecture. But yeah, it's one of those gray areas in medicine, really. You can't really have a very robust method. And thank you.
Thank you, Dr. Manya. May I please request Professor Kameshwar to kindly please share his screen?
Am I audible?
Yes, Prof, you are audible, yes.
Okay, so I must apologize in advance. My Wi-Fi is not working well, but I have two options. So if this fails, I will join another one. There may be some interruption in between, so my apology in advance. So should I start, Pooja?
Yes, please. Yes, please, Prof.
Right. So let me start with sharing my screen. Right. Are you able to see my slides?
You're visible.
Okay. So this is part 2 of this workshop where I'm going to try to bring some application of the grade which Manya so well described to the medical health profession education. And I'm going to do that. I don't know why slides are not moving. Yeah, okay. I'm going to do that through some papers which are already published in the top medical education journals. And one of the paper which I would invite everyone to read, because the whole world seems very much inclined to accept and implement competency-based medical education. And this is a critical narrative review which talks about assumptions which underlie competency-based medical education. And as you can see that this is a narrative review, and the conclusion says the review evidence base is significant but mixed, with limited diversity in research designs and so on. But basically what I wanted to show is that in something which is a hot topic in medical education, the review question was, what is the state of evidence for the core assumptions among the medical education community, or what the medical education community has made about competency-based medical education. And the studies which they included after looking at more than 5,000 studies is quantitative studies 152, which is 80%, qualitative studies 28, which is 15%, and mixed, which was 5%. So you can see that even though, in the beginning, I used to think that more studies in medical education field are qualitative. If you look at least this review on this topic, quantitative dominates. But in medical education, not very rarely, or I would say commonly, you also have qualitative studies, because a lot of educational interventions or decisions are made on educational theories, some pedagogy, and so on. So there is always a conceptual or theoretical framework which underlie educational decisions, and very often they are based on qualitative, which is the inductive method where people describe and then derive some hypothesis, whereas quantitative is the deductive, thereby testing the hypothesis after they have hypothesized something. So I will take both the approaches, starting with qualitative, then quantitative. As you know, this workshop is about quality of evidence. Quality of evidence, as Dr. Manya has already specified, is outcome to outcome. So you have to, whenever you talk about quality of evidence, you have to also ask for which outcome. And outcomes are different from outputs. And I must tell you that Professor Hussam Hamdi only you sort of raised this question in one of our discussions, that we often measure outputs but not outcomes, a very important distinction. So I will like you to remember what is the difference between outputs and outcomes? In education, it is very important. Take one example. Let's say you have some HIV educational project in a community. Then what are the outputs? Outputs are number of workshops you have done, number of participants who attended, number of meetings with the community, number of condoms got dispersed after you have educated the community. Those are the outputs. But the outcomes is decreased incidence in HIV or AIDS, number of people who sought treatment, they got treated and got benefited. So those are the outcomes. So if you keep that example in mind, outputs are achieved soon. You finish the workshop, one is done. You know, so many people attended. But outcomes occur late. Yeah, by this education, by educating people to use condom, and etc., it will take some time before you see that incidence of HIV comes down. Outputs occur at the end of the process. So educational process is over, you can have certain outputs. But outcomes occur long term. Maybe it will take months, years sometimes. Certainly in educational field, outcomes come much later than when you intervene or when you teach or when you implement some intervention. Outputs they indicate completion of a project. So many students passed. We implemented competency-based medical education. So many were competent, but that is not the achievement of the program. Undergraduate program wants to produce or aims to produce graduates who will perhaps serve the community and improve the health of the population. That will take some time. So outcomes will be measured in terms of health gains as a result of the doctors who are produced by undergraduate program. That means it indicates the achievement of the project. It is not about just completion of the project. Similarly, as you can imagine, outputs are within direct control of implementers. So if you are going to implement competency-based medical education, you are controlling everything within the environment of the medical school. Whereas what happens after undergraduates go and serve the community, when they become doctors, that is not within our direct control. So that is another distinction. Outputs are not the reason for the project. Please remember, it's not the community, the state, the society is investing on undergraduate medical education, not only to count number of students who passed, but when we talk about health of population, that is the reason for the project. That is the reason why medical schools exist. So services which your doctors provide, as a result, whatever health gains which population has is basically the outcomes. Outputs do not address the value for the clients. Client for a medical school is the society, the community. And outputs do not address the value for the clients, in this case, the society or community, but outcomes address the value for the clients. So remember, there is difference between output and outcome. We are talking about outcome to outcome evaluation of quality of evidence. Now let's start with first example, and I will start with qualitative studies. There is a systematic review of evidence-based practices for clinical education and healthcare delivery in the clinical teaching unit. So this study actually looked at all the studies which have been conducted where clinical teaching has been imparted to students, residents, and maybe sometimes other healthcare practitioners, and which one has succeeded and how much. And that is more, you can say, qualitative study than quantitative. There are a few quantitative studies as well. And what they did was they used components of, this is also implemented by GRADE, but it is for qualitative studies. And what Dr. Manya talked about is not actually fitting the qualitative framework. So they have their own components which they look at Just as you had risk of bias, inconsistency, imprecision, indirectness, and publication bias, there are 4 things which people look at in qualitative reviews. One is methodological limitations. That is the extent to which there are problems in the design and conduct of the primary study that contributed evidence to the review finding. And I'm talking about qualitative studies. Relevance, extent to which the body of evidence from the primary studies supporting a review finding is applicable to the context. So if you want to implement something which you read in, from USA or Canada, you want to apply to Gulf Medical University, you need to think about relevance. Then coherence. Coherence is extent to which the review finding is well grounded in data from the contributing primary studies and provides a convincing explanation for the patterns found in this data. So as you know, qualitative studies look at themes, look at patterns, and if the patterns are consistent, coherent across a number of primary studies, then it will fulfill the criteria of coherence. Then adequacy of data. People talk about sampling to redundancy in case of qualitative study. You go on doing interviews, in-depth interviews, focus group, that is different variety of collection of data, triangulation, till you find that you have reached a saturation point. So overall determination of the degree of richness and quantity of data supporting a review finding gives another criteria, which is adequacy of data. After looking at this, methodological limitations, relevance, coherence, adequacy of data, you decide confidence. So Dr. Manya was talking about high, moderate, low, and very low confidence in the data in the context of clinical or public health field. But in education or qualitative studies also of interventions in public health field can also be graded into high confidence, moderate confidence, low confidence, very low confidence. High confidence is when it is highly likely that the review finding is a real representation of the phenomena of interest. Moderate confidence when it is likely that the review finding is a reasonable representation of phenomena of interest. And low confidence when it is possible that the review finding is a reasonable representation. So every time there is a reasonable representation of phenomena of interest. When it is highly likely, high confidence. Likely, excuse me, moderate confidence. Possible, low confidence. And unclear, then it is very low confidence. And that is the way they grade in qualitative studies. These are already published papers. Excuse me, those who want to read it more can look at this paper, systematic review, and references are provided. Now, talking about this systematic review, it has studies, 107 studies. So it's not a small number, 107 studies talking about clinical teaching in internal medicine. I'm internal medicine person converted to neurologist, so I like this paper, and you may also like it if you read it. Excuse me. You can see that most of the studies are surveys. As you can see, in this you can't do randomized controlled trials. There are some randomized trials as well, but that's a small number, 16%. Most of them are observational surveys, narrative studies, before after studies, time series studies, semi-structured interview, and so on. So mostly you can say non-randomized observational data, and that's where you may start with low quality evidence in this case. And then you ultimately summarize the whole thing as high confidence, moderate confidence, and low confidence, very low confidence. So you can see that in clinical teaching, I'm not going to go into details, but they have categorized into themes. So first theme was strategy for teaching. High confidence in purposeful rounds in which certain patients are explicitly prioritized for earlier assessment, sick patients, potential discharges. So when I used to go for round, first thing I will say is, let's look at which patients are serious, or which patients have been admitted last night. So that kind of purposeful round. bedside round, when you see all the patients who are admitted, moderate confidence, and so on. So there are different number of studies, as you can see on the right hand side, and it is all related to theme, which is the strategy of clinical teaching, structure of clinical teaching. I'm not going into details, but it will just shows that you have moderate confidence in interprofessional rounds, geographic wards, and duty hour limits, and so on. In the human resources, which means what is the clinical workload of the team, and I fully agree with these conclusions, that if your team has more than 20 patients, then educational experience tends to be compromised. And there is moderate confidence on the basis of 8 studies that limiting clinical workload, such as team having a cap of 15 to 20 patients, may improve the trainee educational experience and reduce adverse outcome. This is the third theme, analytical theme, which is human resources. So what I wanted to show is that in qualitative studies also, they have developed, and it is the grade group who have actually a subgroup working on qualitative studies who have developed this. It has been applied to one, I showed you one example of educational field, and there are many other examples. Perhaps you can look into it and apply it. Then I will come to quantitative studies. Quantitative studies, let's start with educational question. And I took a surgical question, on keeping in mind Professor Hamdi is basically a pediatric surgeon. So not talking about surgery he won't like. So the question which I posed was, among surgical trainees, let's say at Gulf Medical University, does cognitive task analysis based training, I will come to what cognitive task analysis based training is, improve technical performance as compared to the conventional training? So whenever you start assessing quality of evidence, you must have the question very much clearly in your mind. I have set this question in the setting of Gulf Medical University, and we'll see how it impinges on assessment of quality of evidence. Now, I'm sure you have a question, what is this cognitive task analysis based training? I must tell you, before I read this paper, I also didn't have any idea about this, but this is a technique developed by the military, described by Militello and colleagues. What it involves is systematically extracting the cognitive processes behind each key step of a procedure using experts. So, for example, Professor Hamdi is an expert pediatric surgeon. If I'm going to talk about suturing, for example, I will sit down with him and systematically ask what he thinks are the key steps. There may be direct observation and structured interview with multiple experts, which go on describing what is the task sequence, what is the rationale for every step, what are the key decision points, technical tips, potential pitfalls and remedies, and so on. And then you come up with a method which is based on cognitive task analysis. I'm not going into the detail, but it has sort of been thought as efficacious method to gain competence rapidly and accelerate long learning curves. Now, that method was subjected to a meta-analysis in one of the papers which came just 10 days ago. So I didn't want to share with you things which are very old. So if you are interested, you can read this interesting paper, which came on 14th of February. And the outcome, I told you the quality of evidence we are going to look at, but that is outcome to outcome. The educational outcome in this case was technical performance using global rating scores. So the trainees are performing the procedure, and there is a global rating done by some supervisor, and that grading is, let's say, the technical, that is the outcome we are looking at. In this paper, there were multiple outcomes, but I'm only taking technical performance for illustrating the points which we have already discussed. And just to remind you, this is the certainty or quality or confidence assessment criteria. Dr. Manya has already said randomized trials start as high, observational studies start at low, and then it may be lowered. High may go to moderate or low or very low, depending on how much is the risk of bias, inconsistency, indirectness, imprecision, publication bias. Or even low can get to moderate or high, depending on the magnitude of effect and dose response and plausible confounding. So let's look at this meta-analysis of cognitive task analysis-based training. There are 12 included articles in this meta-analysis. 10 were randomized controlled trials, 2 were observational studies. So the weight of evidence is more with randomized controlled trials. So we will say overall we are going to start with high level of quality or certainty or confidence, all the same thing. So we are starting with high. Now we will look at risk of bias, inconsistency, indirectness, imprecision, and publication bias. So this is the risk of bias figure. As you can see, the green color is low risk of bias. This yellow one, some concern. Red, which doesn't appear anywhere in these studies, has high risk. And there is blue color, means there is no information. So about bias in selection of reported results, you remember Dr. Manya was talking about reporting bias, selective reporting bias. That was not clear. There was no information about that. So that's why it's all blue color. That doesn't mean necessarily that the data is compromised, but overall, if you look at, you have to make a judgment whether the risk of bias is serious or very serious or not serious. So I don't know what you will like to, if it was in-person workshop, I would have asked you, but as you can see, green dominates here. So we can say that there is overall low risk of bias. We are not going to rate down the evidence just because, some yellows and blues. Overall, so you have to make a judgment. You may or may not agree with me. We will say there is low risk of bias. Next is inconsistency, also called heterogeneity. And Dr. Manya gave a very good example of students' scores and so on. And when we look at inconsistency, as Dr. Manya said, we look at I-square. So these were the studies, and this is the meta-analysis. This is the line of no difference in the center. Left side favors conventional, right side favors cognitive task-based analysis, task analysis-based training. And you can see that all these studies, the whole confidence interval is on the right-hand side. And this is based on standardized mean difference, not going into the details. And the diamond, which is the summary of all these 4 studies, is clearly on the right-hand side. Even these are all studies in surgical trainees. Medical students, well, don't do that well with this, necessarily with this, not really in consonance with how surgical trainees did. But if our focus is on surgical trainees, so that's why question is very important. We started with a question and we said, so we want to know about surgical trainees, in which case all 4 studies are in favor of cognitive task-based analysis, task analysis-based training. And then Dr. Manya told us to look at I-square. I-square is 61%. So you might think more than 50% we should get concerned. No, I would say that you should also look at all the studies and confidence intervals and point estimates. All these blue dots are point estimates. They are all towards the right-hand side, favoring CTA. And therefore, I won't say there is unacceptable heterogeneity. Remember, when we are assessing heterogeneity or inconsistency, you have to ask yourself, are we asking, is there any effect or not? Or are all the studies looking at the same effect? If your question is, are all the studies favoring some effect in favor of CT or not? Answer is clearly yes. No inconsistency. All 4 studies are saying the same among surgical trainees. So our population of interest is surgical trainees. That means there is no inconsistency. Even if I-square is 61%, that may be because of differential effects in the various studies. We don't have time to go into each study in detail. We can do that if we want to explore heterogeneity, but certainly there is no room, at least to my understanding, to downgrade the quality just because of I-square of 61%. So you have to use your eyeball also, apart from the statistics. Indirectness. Now you see, I posed my question for Gulf Medical University graduates. This study, most studies were done in Canada, let's say, and therefore we have to ask, does this study done in Canada apply to our graduates or not? If you say no, then that evidence is indirect. And similarly, you have to also see whether the training was done in person or in a workshop using simulation, or how was it done? So the method of intervening, what outcomes have been measured? Is it technical performance, as we have highlighted in our question, or are we talking about patient satisfaction or complications occurring in patients after surgery? So depending on what is your population, what is your intervention and comparator, and what is your outcome, it may be indirect. In this review, as you can see, that a lot of outcomes differ. There is technical performance. This is about surgical skill, but there is some differences as well. But so if we are only talking about technical, which is in most of the papers, certainly in the 4 papers, but not in all the 10 randomized trials. And if we are going to look at evidence from all the 10 trials, some degree of indirectness will have to be thought about. So you can see assessment methods also are slightly different across different studies. Outcomes, procedural cognitive knowledge test, that is not technical performance. So you have to think about how much your question and the population intervention and outcome of the systematic review or individual studies are matching. Accordingly, you have to decide about indirectness. In this case, I will certainly downrate for at least indirectness, because our graduates may be very different from US or Canadian graduates. Then having downgraded, high becomes moderate. So now we have come to moderate level. Imprecision. For imprecision, you look at confidence interval. That is where, again, you look at this forest plot. And the diamond, which is here, you have to ask your question. If the effect was 1.17, will we use this method of training? If the effect was 2.96, are we going to use the method of training? I, as an educator, I will say in both the ends of the confidence interval, I'm going to use this method or adopt this method, in which case we are happy with the degree of precision. If at one end we say, no, it is not good enough, or on the other say not good enough, then it is imprecise. So we have to look at that. I would not downgrade for imprecision in this case. And for publication bias, there are, as Dr. Manya told you about funnel plot. You can't do funnel plot unless there are at least 10 studies. So that is one limitation. Of course, there are statistical tests you can use, which we will not go into. But I think for this review, for our question, there are not enough studies to look at publication bias. So we should certainly suspect when there are a number of small studies, and particularly in the field of even in medical education, if some industry funded studies are there and only industry funded studies, you should suspect there may be publication bias. I think Dr. Manya already talked about funnel plot, which should be symmetrical around the summary estimate. And if it is asymmetrical like this, you suspect there is publication bias. And if it is detected, you downgrade the quality of evidence. So overall, we started with high level because of randomized trials. Then we downgraded only for indirectness, didn't downgrade for anything. So it became moderate quality evidence as far as CTA, means cognitive task analysis based training for surgical trainee is concerned. So with this, we come to the end of certainty of evidence or quality of evidence or confidence in evidence estimates. But after this, you have to decide, are you going to adopt CTA? That will require some more things. It will not be only quality of evidence. You will have to look at cost effectiveness and how much time it takes. Is the effect worth the time, worth the effort, worth the cost? Those considerations are, as Dr. Manya said, moving from evidence to recommendation. As far as evidence alone is concerned, as this is the topic for our workshop, I think we have reached that point. So to summarize, there are methods to assess quality or certainty of evidence for both qualitative and quantitative studies applied in medical education. Grade approach is the most commonly used one in public and clinical fields and public health fields, but grade approach is promising even for educational studies with some degree of tweaking which can be done. And I hope you are going to perhaps be interested to read more about it and apply it in your medical education research. Thank you very much. I'm happy to take questions.
Thank you so much, Professor Kameshwar and Dr. Manya. I would request the participants to either request for speaking to our speakers or putting in the questions in the chat box as convenient. If we can take questions from our participants today. Dr. Manya, before in the chat box, we did have a question by Dr. Nabil, and he asked how applicable is the framework, this framework that you explained about, to educational research? And we...
Right, so I think the second part of that, of the workshop dealt with exactly that question. There are a number of concepts that can be applied to medical education and are being applied in a number of forms. The grade approach has been adopted by the circle system for qualitative studies as well. The whole idea of grading evidence is being implemented through that, as well as a number of other systems that are now adopting it. So I think it can be translated. And as was described in the second presentation, it is being utilized more and more in this field as well.
Thank you so much, Dr. Manya. We have another question by Dr. Jaya Kumari. Says, are the output and indicators the same? And I believe, Professor Kameshwar, this question is targeted to your presentation. Yeah.
Yeah, no, the outputs, indicators can be both outcome indicators or output indicators. But the distinction which we have to keep in mind is between outputs, which is at the end of, let's say, undergraduate curriculum, and outcomes, which are after the doctors go into the community, and whatever health outcomes we achieve, that is something which is a real outcome. So there may be indicators for outcome also, indicators can be for outputs also.
Thank you so much, Professor Kameshwar. I would just interrupt in between a little. We have our Professor Hassam Hamdi, our Chancellor.
Good afternoon, everybody, and I would like to thank Professor Kameshwar, Prasad, and Dr. Manya for accepting our invitation and contribute to this important international conference. And I can tell stories for, maybe I could have a whole workshop talking about Kameshwar and what we have been doing together for many, many years. And I wanted the whole world, although he's very well known internationally, but at least 3,000 participants in this workshop are following you, Kameshwar and Manya. I think today in the workshop, at least 150 are with you, and tomorrow there are almost 3,000 will be participating in the conference. So thank you very, very much. I heard at the beginning you were mentioning our name and work together on the difference between output and outcomes, which still you are struggling with it, as you know.
Yes.
I look forward to meeting in person very soon. And once it seems this pandemic is getting, the situation is getting much better now. So
Yes.
traveling will be much easier. And I know without hesitation, all those who have attended this workshop, they have learned a lot. Learned a lot from the guru, the father, but also learned a lot from Manya, which carry, I think there is a gene called, which has been going, transmitted, a very strong gene about evidence, the evidence gene. I think I should talk about that, evidence gene, yeah. So thank you very much, my dear friend and brother, and thank you very much, Manya.
Thank you so much, sir. Thank you for the opportunity, and wonderful seeing you as always. And thank you so much. You're an inspiration, of course.
I leave you to take more questions.
Sam, thanks for inviting, and visit is long overdue. I think we have got to meet in person. Right.
Thank you.
Thank you very much.
Thank you so much, Professor.
Thank you. We can leave now, Dr. Pooja. Don't feel like leaving, but I have to feel.
There is this one small question that I have from one of our participants, Mr. Omer Amir, and he asks, shall the high indirectness affect my meta-analysis very negatively?
Well, not necessarily the meta-analysis, but we are talking about evidence which is graded as regards its quality, which emerges from the meta-analysis. If there is meta-analysis, won't be affected, but the quality of evidence which we will grade, which comes out from the meta-analysis for the particular question, may be affected because of indirectness.
Thank you so much once again, sir, and Dr. Manya. Thank you so very much for your presence. Thank you. Thank you once again. Thank you.
Thank you. We want to attend the conference, Pooja, so I don't know whether the same link will work or not. I want to attend some of the lectures tomorrow.
The same link, yes.
Okay, right. Thank you. Thank you very much.
Thank you, participants. Thank you so much.
Thank you all. Bye-bye.
Thanks everyone for attending. I must thank those who paid their attention to our workshop and our lectures. Thanks a lot.